जोर से बोलो। बोलो आप लोग क्यों हाथ उठा रहे हैं? यही हमें करना है। तो आज का हम लोगों का मेन पर्पस है डे टू डे बेसिस है ना, कि हम लोग डीबीटी फॉर्म के लिए अपने आंख को तेज करेंगे, है ना। तो बोलते हैं कि आई डू नॉट सी व्हाट माइंड डज नॉट नो। तो पहले आज माइंड को हम लोग बता दें कि डीबीटी होता है, इन्हीं मरीजों में होगा। और हमारे पास एक टूल है उनको पकड़ने का, पकड़ने के बाद भी हो जाए, लेकिन कोई बात नहीं, लेकिन हो गया, हम लोगों ने कोशिश तो कर दी बचाने की, तो ये करेंगे।
ये टूल थोड़ा ज्यादा कॉम्प्लेक्स है। मेडिकली मैनेज पेशेंट के लिए सिंपल सा
पेशेंट बस कैप्रिन इज पेशेंट। हां, कैप्रिन इज
सीओपीडी में पेशेंट्स में जैसे आपको क्या बहुत सारे सीओपीडी पेशेंट्स आते हैं, तो इसमें व्हाट डू यू थिंक इज द रोल ऑफ लो मोलेकुलर वेट?
In COPD patient, like we have to first differentiate with if the patient in two categories basically, if it is critically ill or just an acute illness. Critically ill, by that I mean that if the patient is requiring mechanical ventilation along with use of intravenous catheter. So in that circumstances, the patient will be probably immobilized for a prolonged period of time. In that case, we will get a very high score for in the Capillary model. In that case, it will be wise to start the prophylaxis at an early stage.
कितने बार हम लोग कर लेते हैं करीब सीओपीडी पेशेंट्स को हम लोग देते हैं एंटीकोगुलेंट?
Generally, sir, in our practice, we start patient on prophylaxis. Most of the patient who require mechanical ventilation.
डॉक्टर दीपक, जैसे आप लोग प्रिस्क्राइब करते हो, फाइनल प्रिस्क्राइबर होते हो एंटीकोगुलेंट्स के, एक क्वेश्चन पूछा जाए कि इस एंटीकोगुलेंट सेफ along with thrombolytics?
For pulmonary embolism, we give thrombolysis. In massive pulmonary embolism, which causes hemodynamic deterioration. In pulmonary embolism, as such, we don't give anticoagulation with thrombolysis. We withhold anticoagulation, then thrombolyze. After thrombolyze, we restart anticoagulation.
Okay. यहाँ पे हमारे पास कार्डियक एनेस्थेटिस्ट भी हैं, डॉक्टर दीदी, है ना? How should you approach recurrent VT despite anticoagulation?
Very often, despite anticoagulation, we see patients if the health function is poor, those patients need and the cause can be poor health function as well as cause.
नहीं तो उसको हम लोग अप्रोच कैसे करेंगे कि रिकरेंट वीटी हो रहा है एंटीकोगुलेशन से, हमें उसको ड्यूर करना है, नहीं करना है, क्या करें हम लोग? अप्रोच क्या होना चाहिए? जब वाल्वुलर हार्ट डिजीज है, क्या करना चाहिए हमें?
So we start on anticoagulants as well as anti-arrhythmics as well to control the rate, but this is only prophylactic. It will gradually subside with time.
आईवीसी फिल्टर, तो आईवीसी फिल्टर क्या हम लोग लगाते हैं अपने हॉस्पिटल?
Yes.
लगाते हैं। हाँ,
First of all, we should check the if patient is taking drug or not. Sometimes patient is stop the medication, then it can offer recurrent DVT. If on medication recurrent DVT is occurring, then we should place RBC filter to reduce the pulmonary embolism chances. We have done here quite a few cases.
हम जीडी पूछें डॉक्टर दीपक आपसे, how often PE mimics MI in ICU patients?
Usually not. We have such ECG and echo. We can differentiate easily between the MI and pulmonary embolism.
तो जब DVT हो गया और फिर pulmonary embolism हो गया, how should we manage pulmonary embolism?
If pulmonary embolism mild to moderate, then we can start anticoagulation only. And if it's massive, then we have to thrombolyze the patient or mechanical thrombectomy options are there. So we should thrombolyze the patient if having massive pulmonary embolism.
डॉक्टर पंकज, आपके पास बहुत सारे पेशेंट होते हैं, वो आप क्रॉनिकली बेड हैं। आज के देखा जाए तो मैं तो साल में हमारे पास ICU बेड्स हैं, तो आई थिंक 50% में भी स्ट्रोक एंड वो क्रॉनिकली बेडेड। So how often you see pulmonary embolism or DVT in them?
So actually, in our practice, we are seeing pulmonary embolism or DVT in our spine patients only, sir. So जो long segment spine surgeries हो रही हैं, we are fixing spines more than 5 levels, intra-op time is more than 6 hours. मैंने जो भी देखा है, I've seen in those patients only. And for those patients, we have started the intra-op DVT pumps. We are giving DVT prophylaxis from intra-op only, and then the incidence has significantly reduced. But those patients, every 10, I should rather say, for every 10 patients, we see 2 to 3 patients with shortness of breath on 5th, 6th day. We get evaluated from the cardiologist. Mostly they come out to be some effusion, some fluid overload, but 1 out of 10 is always embolism, and then they take care of that. Regarding stroke patients, because they are on continuous physiotherapy are visiting daily, so as such stroke में इतना नहीं देखा intra hospital, maybe when they get discharged, sometimes they don't come back and
नहीं तो हॉस्पिटल अगर हम देखें क्योंकि
Intra
हमारे
hospital-
यहाँ पे पेशेंट महंगा रहता है
Intra-hospital, but I have seen this is only with spine patients with long segment fixations where we are doing. Those are the patients who maximally suffer from this.
बिकॉज़ एक थ्योरी एक और बात होती है बट एक्सपीरियंस एक्सपर्टीज भी एक चीज होती है कि अदर देन एविडेंस बेस्ड मेडिसिन योर एक्सपीरियंसेस दे कैरी लॉट ऑफ वेट. डॉक्टर साहब आप ऑर्थोपेडिक्स में हो डॉक्टर साहब, यू इंट्रोड्यूस योरसेल्फ एंड टेल अस कि आपका क्या एक्सपीरियंस है, यू डू PCA
Sir, in routine cases, routine lower limb surgeries, we always use a low molecular weight heparin prophylaxis. In every case, I mean, in patient with age greater than 60 years and in lower limb surgeries, we definitely use one or other form of DVT prophylaxis. And because of this, we have very few cases we have seen in post-op patients developing the DVT. In trauma patients, yes, that is a different thing. That there is a fat embolism leading to pulmonary embolism. We have those patients. Those are managed with a high flow oxygen and mechanical ventilations. But we routinely use DVT prophylaxis, and because of that, our DVT rate is very low with us.
डॉक्टर अंजलि आप कैसे हो, मैंने गांधी में हो आप ऑफ में तो प्रैक्टिकली आप तक अभी आप यंग हो प्रैक्टिस में, लेकिन आप प्रैक्टिकली आप तक प्रेगनेंसी में हमने बहुत सुने प्रेगमा डोलेंस होता है, प्रेगमा और होता है लोअर लिम्स के एंड DVT होता है, आपने आज तक कितने देखे?
So not very often. So pregnancy itself is a hypercoagulable state. So in high risk patient, I personally give DVT prophylaxis 2 days after surgery.
Also, sir, for stroke and CP, most of these patients who are getting some sort of anticoagulants or some antiplatelets. So these patients, like I would rather say कि नहीं होता, but जो trauma patients हैं, young patients हैं, they sometimes we have seen with DVT and in spite of
ये DVT है, वेनस थ्रोम्बोसिस है, इसमें एस्पिरिन की क्या रोल है?
Aspirin is effective somewhat, but anticoagulation is more effective. That's why I am saying that aspirin and DVT pumps, these are effective, but only in mild cases. The chances of DVT is mild then. In patients with chances of DVT are moderate to severe, we have to give anticoagulation with DVT pump.
See, all these lower molecular weight heparins, they were born in perhaps in 91 when we started our medical practice, and we grew up with that. Now आप क्या करके oral anticoagulants आए, नहीं तो एक वक्त से देखा जाए तो वार्फरिन पे हम लोग सेट थे और वार्फरिन की प्रैक्टिस करते थे. तो आपको अब क्या लगता है कि जो नए आए हैं डॉक्टर और बाकी ड्रग्स आए हैं, आप लोगों ने यूज किया होगा, तो आप लोगों का क्या एक्सपीरियंस है?
They are definitely better than warfarin because warfarin has a prolonged onset of action and prolonged offset of action also. So it's also difficult to use and also requires like regular monitoring of PTINR. So rivaroxaban and apixaban, they are fixed dose and relatively easy to use and no monitoring is required. So safer also.
डॉक्टर सोनी, हमारे पास सब कुछ है. We are no as a hospital we are low rate hospital, but we are no low resource hospital. हमारे पास सारे रिसोर्सेज हैं पी मैनेज करने के, पी डायग्नोसिस करने के. तो हम कैसे डायग्नोस कर सकते हैं पी को अपने प्लमोनी इम्बोलिज्म को? अर्ली
सबसे इम्पोर्टेंट हम इको कर लें. इको आपको अगर सीवियर मैसिव थ्रोम्ब एम्बोलिज्म है तो उससे वो दिख जाता है कि आगे आदमी डायलेटेड है, सेप्टम शिफ्टेड है, यू नो कि कार्डिक टैम्बुलेट में, तो आप इजीली उसको थ्रोम्बोलाइज कर लेंगे. ईसीजी करते हैं, ईसीजी बहुत रिकमेंड नहीं कर रहे हैं, ठीक है बुक्स कहती Q1 S1 T3 पैटर्न होता है, बट वी डोंट यूजुअली वेस्ट टाइम ऑन ईसीजी. और डी डायमर टेस्ट वो आपको हाई सेंसिटिविटी है एंड वो आपका सेप्सिस में भी पॉजिटिव हो सकता है, पल्मोनरी एम्बोलिज्म में भी पॉजिटिव हो सकता है. बस ये उसकी नेगेटिव प्रेडिक्टिव वैल्यू बहुत है. अगर डी डायमर आपका नेगेटिव है देन यू नो कि वो आपका वीनस थ्रोम्बोएम्बोलिज्म नहीं है. और गोल्ड स्टैंडर्ड इज सीटी पल्मोनरी एंजियोग्राफी. अगर सीवियर केस है डायरेक्टली गो फॉर सीटी पल्मोनरी एंजियोग्राफी एंड डायग्नोसिस.
the last compliment I will give that with their knowledge, experience, skill, evidence, what they have acquired over the years, 123 years का रिसर्च जो है इस टीम ने हमारे पैनल ने आपको दिया और बाकी डॉक्टर्स ने भी कंट्रीब्यूट किया। इसके अलावा अगर किसी को कोई क्वेश्चन पूछना है तो पूछ सकते हैं, लेकिन इसमें जो मोस्ट इम्पोर्टेंट टेक अवे मैसेज है तो बोलते हैं वॉक दी टॉक। तो टॉक को हम लोगों ने ले लिया कि प्रिवेंट हो सकता है, कैसे प्रिवेंट करना है, अब कल से हमें उसको वॉक करना है, कदम बढ़ाने चलना है। अगर इम्प्लीमेंट हो गया तो सक्सेसफुल है। उसके लिए हमें वो जो चार्ट है आईसीयू की, जो सिंपल चार्ट है, भरने हैं और पेशेंट को पिकअप करते हैं। वी होप दैट वी विल डू इट फ्रॉम टुमारो इन ए बेटर वे। वी आर डूइंग, कल से और भी अच्छा करेंगे एंड विल प्रिवेंट वेरी थिंग। नाउ विल आई लीव द panelists open to the house. Anybody can ask any question and clarify your doubts. But they have given you a nutshell in a very short period. 123 साल, 125 साल का रिसर्च और नॉलेज आपको इन्होंने 15 मिनट में दिया। I think we can do it.
Same thing. Can aspirin be given in patients who do not tolerate rivaroxaban or any other? Can aspirin be given?
Aspirin along with DVT pump can be given for patients who are at low risk or who are not able to give anticoagulants.
Okay.
In them only when we can give.
Aspirin,
The patient is
but with
monitored for
DVT
life
pumps. But with DVT pumps.
along with DVT
Sir,
pumps.
OPD basis पे जैसे कोई operated
Then
patient.
aspirin we can give if anticoagulants are not, if anticoagulants are contraindicated, we can give aspirin alone.
And doses by 75, 150.
75, 81 mg. But aspirin, but anticoagulation is more effective
Exactly.
than aspirin.
Gold standard is anticoagulant.
Just the basic understanding is if there is a platelet related thrombus is there, then obviously antiplatelet works. But if it is a red clot, then obviously anticoagulant will not work.
Because definitely low molecular weight heparins are for anticoagulation, not for antiplatelets. Aspirin is for antiplatelets, but some patients do not tolerate these things.
Yes, aspirin is effective, but less than anticoagulation. Also, high index of suspicion is very important. एक पेशेंट याद है, शायद को भी याद होगा, 30 years मेल, वो वॉकिंग पे गया था, वॉक पे सडन कोलैप्स हो गया। केवल ये हिस्ट्री लेके मेडिकल आईसीयू में आया था। मॉर्निंग का टाइम था कि कोई हिस्ट्री नहीं, और मैंने ने बोला वाइटल शुगर बीपी लो था। मैंने इनको देखा तो आगे आगे डायबिटिक, और उसी टाइम तुरंत केवल सस्पिशन पे उसको थर्मलाइज कर दिया था, और आधे घंटे बाद वो ठीक उठ के बैठा हुआ था। अगर नहीं डायग्नोस होता तो डेफिनेटली उसका सर्वाइवल काफी मुश्किल होता। तो किसी भी पेशेंट में हो सकता है, यंग एज में भी, इवन विदाउट एनी प्रोवोकेटिंग फैक्टर, विदाउट एनी सर्जरी ट्रॉमा, pulmonary embolism can occur.
Elective cesarean also get a prophylaxis, or we need to get the risk score?
Risk score.
I think so. With the pregnancy factor, with surgical part, the risk will come as more than 4.
Yeah, more than 5. If the risk score is more than 5, then we have to.
Not routine.
Not every patient. There is मैंने मेडिकल साइंस में ना ये हमेशा याद रखना चाहिए कि नथिंग इज फॉर एवरी पेशेंट।
Sir, I lost a cesarean patient. Day 2, she just went to toilet. She came back, she collapses, and it was major pulmonary embolism.
It happens, but we cannot give it to every patient. For anything in life, we have to see the risk and benefit. Suppose we start giving anticoagulants to every patient, no one will happen. How many will kill, we don't know. Because these drugs are highly drugs with a very low therapeutic window. They are high risk drugs. They can lead to side effects. It is not absolutely safe as we claim. है ना, तो हमें देखना पड़ेगा क्या दे सकते हैं, क्या नहीं सकते हैं।
Just one point I want to stress in this: all the patients who either in OPD or who are admitted ward or ICU, if they complain of acute onset shortness of dyspnea, in the first diagnosis that we should rule out immediately by any means is an acid. No other even an MI will not cause such a quick mortality as an acid embolism. Even if hypertension, etc., whatever it may be, it will not cause such a massive sudden mortality as a massive embolism. So first we should rule out massive embolism, then we can do anything we want.
Sir, suppose we have such a situation in our ward, the first reflex will be to call for cold blue. So
Acute onset shortness of dyspnea, may or may not be that depends
may
on
or may not. But if she collapses along with that, so in that case the CPR can be done in that, even if it is PFR.
That
has to be done.
CPR
But then,
तो underlying है ना।
on the bed, echo should be done at the bedside.
नहीं, आप देखो, इसे आप कोल्ड ब्लू को बुलाते हो, the patient is not dead, patient is still gasping, they will take the patient with them, either to the emergency or to the ICU, and they will handle it because they do it every day. They will handle it. It is code blue of the नाम दे दिया है. Basically, it is a rapid response team. So any symptom which you are not able to manage, based upon the early warning sign, you raise the code. Patient might not be having cardiac arrest. It is a rapid response team. It will come and help.
I personally, when we are in doubt what happened to the patient and you are suspecting in the back of the mind that some clotting factor would have happened, so during CPR I give the bolus heparin dose.
5,000.
Yes, 5,000 units I just
That was not acceptable, so we let it go. But
This patient, I just wanted to stress a point is that apart from screening, on the OPD basis also and on the and the OPD basis also, this patient should have been kept on continuous anticoagulation, oral anticoagulation, because he had recurrent miscarriages and his anticardial was positive and he was suffering from Epler syndrome. She should have been on anticoagulation for
Before surgery.
Before surgery, also on a routine basis.
Yes.
That is what we do. If the patient comes, she came with a missed abortion already
Yes,
with the report. Otherwise, this is the protocol. We start LMW immediately.
So screen it, you can screen, keeping the high index of suspicion that it may be there, then put on prophylaxis.
And I'd like to add, in such cases,
Even if you screen for DVT, you might not find anything because that part is already embolized and you come with that consequences. So that might be fairly normal.
so we know that who are the high risk patients for VT, and your patient was for a high risk. So next time when we get, we should try to be more careful, try to give the prophylaxis before the surgery, and we can learn from that patient. So, and you have also know now how we can identify. You can follow that at any chart that.
Patients of cancer who are on chemotherapy or radiotherapy. There are many patients on my follow-up who are being treated on OPD basis.
So if I ask you in a month or in a week, how many patients of DVT or sequelae you get in your OPD?
Yeah, in a month there are 3 or 4 patients which are being referred to me for treatment part only.
Anybody want to ask any question, Dr. Silpa? Dr. Anjali?
So recently, just last Saturday, I lost a patient, young patient. She was third gravida, abortion 2. She had 2 miscarriages, and I was planning a hysteroscopy, suction evacuation, and wanting to send the products for karyotyping. I was in the procedure. According to me, she was a known case of epilepsy. She had already taken her morning pills. Apart from that, she was not any high risk. She collapsed on the table, and the anesthetists were there. 15 minutes after the procedure, first her saturation started falling, then suddenly her heart sank. Young patient, 23, 24 years old, no other comorbidity. And 3 of my anesthetists, within 5 minutes, they had to give shock also. Thrice shock, not even a single sign of revival. She was an ambulatory patient, she was properly mobile. I did her PT-INR and immediately the coag profiles, they were also okay. So, one thing is, last year her report was ACL positive, anticardiolipin positive, but when we had sent it repeat here, all the profiles were negative. ANA negative, ACL negative, phospholipid negative, and lupus negative.
There were predisposing factor in this patient, ma'am. Actually, she was pregnant with some sort of complications related to pregnancy, and ACP was positive in some reports. So it would have been screened for DVT preoperatively, keeping the high clinical index of suspicion. Or it would have been better to assess this patient with the Madam said Caprini score or some other score, where C stands actually.
Rather than taking her
Yeah.
we could have opted for this option.
Exactly.
Multiple abortions.
Exactly.
one more thing is there, if patient is add to the prognosis of DVT in patients. So if they are on a long term in the hormonal therapy, then obviously the chance of DVT may arise.
Sir, in case evaluation was done, would there have been a pre-op part?
First is clinical examination, ma'am. History is most important. Any leg pain, swelling, what everybody is familiar with that. And if you need a further investigation,
Likely suffering from antiphospholipid antibody syndrome, anticardiolipin positive, anticoagulant positive, and history of recurrent miscarriages. These patients are prone to develop recurrent arteriovenous thrombosis. It may be de novo thrombosis of any artery or any vein in the body, and it looks like she had episode of massive pulmonary thromboembolism. So maybe we have done a duplex scan of leg. It may have.
we encountered, but it's not that often. And A is like it's not common presentation as such. It's a rare presentation, and often not the even if it's there, it's like presents as a masquerader, because most often there are other underlying conditions, and as such it's not always an initial diagnosis. So it's not very common presentation as such A, but if it is fairly present, and we often encounter it.
So slowly how often you see?
So actually with NEPH protocols within our hospitals, we have these DVD forms in all the ICU files, and the repeated awareness programs, they have caused this incidence to decrease, and we encourage early ambulation of the patient, and the limb physiotherapy on the rounds, they all are features in which we are preventing the stasis, and when required we are giving thrombo involved in this thromboprophylaxis. So with awareness, the incidence has actually decreased very much.
Dr. Deepak?
Definitely DVT is not very common, it is uncommon nowadays, but when it occurs it has significant morbidity and mortality, and most of the cases are undiagnosed, so we have to keep a high level of suspicion to detect DVT and pulmonary embolism.
How often you receive a call from different ICUs or different places to do a echo to rule out thromboembolism?
Almost 1 a month we get it.
Once in a month. Okay. But anyways, what is your view? How often you receive a call?
I think most of the times when we get a call for DVT is not for, generally not a call for DVT, generally it's call for acute onset shortness of breath. Sometimes from orthopedics or sometimes from other wards we get a call for acute shortness of breath, and when we evaluate the patient, generally we have made a diagnosis of massive pulmonary thromboembolisms. But there is at least a 30% 40% evidence of in those patients of iliofemoral DVT. Not a, I would not say lower limb DVT, populated below populated DVT. The patients who have iliofemoral DVT incidence have a high incidence of pulmonary thromboembolism, and generally this is the main cause of mortality in patients of DVT. Otherwise, DVT, prolonged DVT may cause other morbidities, but mortality is basically because of pulmonary thromboembolism.
Once a week or once a month you get a call?
Generally yes. Well, at least once in 15 days, twice in 15 days, we get a call of acute onset shortness.
Looking at the global scenario, this problem is so great, around 1,600 deaths per year are because of this clotting in the veins. And of all this clotting, 60% occurred in the hospital itself or recently after hospital discharge. So this being the #1 cause of preventable death, we should we are being collected here to spread awareness. Now to see actually the magnitude, how prevalent is this problem, some studies were done. In 2006, Sir Gangaram Hospital study was conducted, and they screened the DVT patients, and they got the lung scan done. And these DVT patients, around 39%, they were showing some features suggesting clots. And of these patients,